Okay, hi, my name is Michael. I will be demonstrating the skill of RSI preparation for a 40-year-old gentleman who has fallen off a roof. This is for the paper contemporary to Paramedicine. On we go. Hello sir, can you hear me? Okay, having a good look in his airway. Can't see anything, can't see any teeth knocked out, any blood, any vomit, which is good. Very gently just holding his airway still as I check for his breathing. He is breathing, you've got good chest rise full. Alright, and now looking at my patient, does he have a radial pulse? And what is his skin colour? Is there any obvious signs of bleeding? Because there's a trauma, because he has fallen quite away. Just gloves on, quick pat down, quick blood sweep. And right underneath his back. Checking my gloves intermittently. Alright, no obvious bleeding, apart from just around the back there. It doesn't appear to be hemorrhaging out quite significantly. However, there is a bit of blood at the back of the thing there. So very quickly do a secondary survey, starting with the GCS. So sir, can you squeeze my hand for me? Sir? So we've got no response. He does appear to be posturing. So we'll give that a 3 for his motor score. His eyes are not opening. Not opening at all. Is it a 1? Yeah. Not opening at all. We've got a 1. And then he is moaning and groaning, making up a 3. 2. So 6. Okay. Alright. Secondary survey. We on the radio. AET1 calls control.
Go ahead.
Status 1 patient. Can we have the availability of an RSI officer?
10 minutes away.
Copy. Can we get them coming towards us? TBI. Status 1.
Roger.
Go.
Copy.
This patient appears to be hemodynamically stable. We've got good colour, warmth. He has a regular radial, bilaterally. So we're going to prepare for our RSI assist whilst we wait for our ICP, who is RSI capable, to arrive. Starting off, opening everything up. We get our airway gear out, IV gear, towel. First, what we'll do is we'll size up a adequate airway, an OP. He doesn't require this at the moment. Then we're going to get him on some nasal prongs. We're not going to attach this to any oxygen, just going to have it there for when we are intubating. Place that out of the way. Alright, we'll put this on you, sir. So I'm just attaching a non-rebreather to our patient, being very aware that he does have a high mechanism of injury, so I don't want to be moving his neck too much. At the same time, immobilization is only going to hinder us down the track. So we've got him on 10 litres to fill the bag up. We're cracking it down then down to 8, but we'll get him on that first. We've got an airway device here. We have our bag valve mask set up with oxygen tubing, again going towards our oxygen bottle. Only one at this stage, but our ICP will also bring with him another one, or for in the back of the truck to connect that to the bulk. Peep set to 5, and just down there by the hip. I'll also then get my capnography attached to the airway circuit. And allow that to calibrate. Fantastic. Then also get the patient in the sniffing position by very gently positioning his head and using a rolled towel. Finally, getting a suction and placing that under there should that be necessary. Airway now looking sorted. My Thomas tube holder also in place for when the time comes. And clearing up and leaving the airway space available for our RSI officer to come in. Now moving down further down the body, now we've got that airway sorted. I want to come down and attach the monitoring equipment, whilst also gaining a set of baselines. Put my SpO2 on the finger there. If I had a bystander, get the bystander to stand up here and just support the airway whilst I'm doing the next few checks. Get the monitoring equipment, so a quick 3-lead on the patient. There we go. And where's she gone? Our blood pressure cuff, then also attached to the patient's forearm, and we'll start that up. Okay, monitoring equipment is now sorted. Move on to my IV lines, preferably large bore bilaterally in our ACF, or central proximal to the heart. I'll do one on this line, on this arm, sorry, and then for the purpose of demonstration, we'll say that we did another on the other side here as well. Sharps container out. Again, large bore, so we'll go with something like a 16 or a 14, as big as the vein will allow. There's my alcohol swab. Set up a running line, ensuring that there are no bubbles through there before attaching it to my large bore IV access. We'll leave that off for now and just have that there. Again, large bore on the other side also, cleaning up as I go. At this stage, what we've done is we have gone from our airway first, then we've gone to monitor or vital signs, and then what we've done is we've gone for the IV access bilaterally. At this stage, I feel that I am prepared. I would then stop, check my checklist, preferably with somebody else. RSI preparation checklist is on my phone, so I'll just go through that. I've attached nasal prongs. I've pre-oxygenated the patient using a reservoir bag. We'll keep that at 10, not at 8. I've attached my monitoring equipment, and I've done a first set of baselines, which I would then repeat before the arrival of the ICP. I've got end tidal CO2, and that's been calibrated. Position the monitor so that the airway person can see it. Gain IV access, 2 sites. I've got a running line prepared. I've got a folded towel under the head for the patient to be in the sniffing position. End tidal holder here. Suction is working. I've got my manual with my PEEP attached. I'll tan another set of vitals now, and then clear the area so that we've got both sides accessible. Thank you.